Our final speaker this morning is my colleague, Dr. Venexia Walker, who is an epidemiologist in the University of Bristol Medical School and specifically in the Integrative Epidemiology Unit in our department, as well as at the University of Pennsylvania Perelman School of Medicine. Her research covers causal inference using electronic health record data, as you'd expect, and also, if I can mention the dreaded two words, Mendelian randomization, particularly for the study of drug effects. Venexia's been working in these secure data environments since 2020. She's very enthusiastic about the potential to promote open science embodied in these environments, and that's what she's going to talk about now. Venexia.
Thank you for that introduction, Jonathan, and the invitation to speak. So, as Jonathan said, I will be talking about opportunities for open science when we're conducting causal inference in UK electronic health records. So, as hopefully many of you are aware, open science is a movement to make the science that we do and its dissemination more accessible, reproducible, and inclusive. And there's a number of ways that we can do that, and I'm going to go through each of these components in turn and hopefully persuade you that the UK electronic health records adopt these principles. So first, starting with accessibility. So in the UK, the research councils and charities that fund us require us to publish open access scientific publications. But alongside that, when we're working with data in secure data environments, we are pre-specifying protocols and we're making those publicly available alongside our publications. So even before you see that final output at the end, we are also pre-specifying and sharing what we're doing. The focus is for accessibility is really the software, because we are working with some of the most sensitive forms of data here. So we're never going to be able to make electronic health record data open data. So our focus has to be on making the software that we're using and describing how we're getting from data to analysis, the focus of making this accessible. So we're relatively fortunate in that because the data are collated nationally, they are well documented in data dictionaries, and we can describe how we're getting from what people see in the data dictionaries to our analysis-ready data set. So to do that, there's a couple of things you need. We've mentioned the use of code lists. So code lists are lists of clinical codes used to define diagnoses or prescriptions in the electronic health records. Open Safely offers a complementary website called Open Code List that allows us to generate our code lists collaboratively and share those openly. So you can define the exact same variable that we are defining. We also share the code that we use to prepare the data so that you can, once you've defined that variable, get to that analysis-ready data set. And we're really committed to standardizing our code wherever possible. So in light of Miguel's last question, we recognize that there is commonalities between our different projects, and we are likely to move code between them. So if we standardize, we can make it accessible to new researchers starting new projects because they know what they're looking at. The projects are similar. So the second component I want to speak about is reproducibility, and the focus on this is really the open analysis tools and frameworks that we're working within. So again, Open Safely has a built-in process supporting reproducibility. So while we can't share sensitive electronic health record data, we can share our dummy data. There's absolutely no risk of disclosure there. Alongside that, built into this process, the code is ending up publicly on GitHub because we are using GitHub to submit it to the secure environment where it's analysed. Open Safely isn't alone in this commitment to openly sharing code. So some of the other environments, including the NHS England secure data environment, require code sharing as part of the access agreements that you sign when you start using these environments. So on top of all of that, making sure we're sharing our code, we're trying to share our code in a good way. So We want to reuse code wherever possible, and one of the best ways to do that is to develop well-documented packages in order that that reuse is really facilitated. We're also trying to use common language across our projects, so using consistent variable names, consistent code components. These all sound like very simple things, but they can really help move code between projects quickly and efficiently. And during the pandemic, that was particularly important because we were responding rapidly to challenges as they arose. We also have made commitments to code review. So we are trying to review all the code on these projects. And when we're doing that, we're thinking about lots of things. Does the code work? But also, is it reproducible? How can we make it as generalizable as possible so next time when we come back to it, we know what we're looking at and we can use it again. So just to give you kind of an example of all of this, picking up on Will's talk and all the vaccination projects he mentioned, this slide visually demonstrates 18 different vaccination projects and how they were linked and how the code moved between them. And what you'll notice about these projects is they were led by different institutions. So code really did move around between these different projects. So the last element of open science that I want to draw your attention to is inclusivity. So thinking about supporting diversity and expanding participation in research. So as I hope demonstrated by the range of speakers we have here today, key to the success here has been strong cross-institution collaborations. We have worked together, and I think that has made us more productive and done better science than we might have done otherwise. Each of the secure data environments that we work in has an active user community, and by talking to other users, we can overcome some of those day-to-day issues that you face. And those users reflect a broad range of specialities. So we've got clinicians working alongside methodologists, epidemiologists, we're all in there together. Alongside the specific user communities for the different secure data environments, there are a number of us that work in multiple secure data environments. So we can bring learnings from one environment to another and improve things. I also want to mention about inclusivity in terms of the people that we're doing research for, not just the people that are doing the research themselves. So this greater access to data, the near population coverage, has allowed us to expand the people that are included in our research. Before, when the data were fragmented, the small sample sizes meant that groups with low counts weren't available to us for study because we couldn't disclose their information because of the low counts. With near population coverage, we start to be able to research for those groups. So in summary, open science is made up of accessibility, reproducibility, and inclusivity. And we think that the UK electronic health records are allowing us to adopt these principles of open science and perform good causal inference. And we hope you do too.